And it is still January 17th. And today we have our first walkthrough that we've done. And we have Jen Carpy from Ledge Council.
Good afternoon. Thank you. Jen Carvey from the Office of Legislative Counsel. We are going to be doing a walkthrough on H31, which is an act relating to claim edit standards and prior authorization requirements. But I wanted to just give you a little bit of a refresher or grounding in what where these issues come from first. So what I'm actually going to put up first is an act from last year. Act 111.
While you're doing that, can I ask our committee assistant, Kristen, I don't see the bill on our page under today's date.
H31.
Well, in other words, like on today's date, there's not a Jen Carpy with can we have the H31 posted?
It's just from the website.
Sorry, maybe it's me. I just like it. It usually gets posted under Jen Carpy.
Well, we're going to look first at Act 111 from last year, just for a little bit of kind of context. Jump in. Act 111 from last year was H766 when it was considered in this committee. So for returning members, that's what you may remember. This was the bill on prior authorization, step therapy, health insurance claims and claims editing, and provider contracts. And part of what you may remember is that we came back and made a couple of tweaks to effective dates in Act 111 during the veto session. Ours was the only bill introduced, taken up, passed through both chambers, and enacted all on the veto session day. So that was Act 185. But that doesn't affect really what we're looking at right now. What we're looking at right now, and I'm going to go to Section 2 of this Act. First had to do with claims edit standards. So these are the standards by which health insurers make changes to claims that are submitted to the insurer for payment on behalf of covered individuals, beneficiaries of the plan. And so there, we had some provisions already in statute that were that set out a bunch of parameters for those for processing claims and down coding and adherence to coding rules. And in Section 2 last year, we amended that existing law in a few different ways. And part of that was setting some alignment with the claims edits allowed in the Medicare program for outpatient and professional services and for facility claims. A few different kind of standards that are used in Medicare. Some other nationally recognized edit standards, guidelines, and conventions for pharmacy claims, and then kind of a catch-all provision. And then we had a provision saying when adherence to those standards was not required. And that's where the language we're going to look at comes from. And so it was adherence to those standards is not required when state or federal law or other provisions require, or if it's better for providers to go with some different edit standards and certain processes have been followed. So that was the piece on claims edits, was setting out some new standards that have to be followed and creating some exceptions. The next section of the bill and then we'll go to this year's bill and look at what you're doing or what you may be doing. Section 3 of the bill put out or created a exemption from the prior authorization requirement. So if you're not familiar with health insurance or health coverage generally, often there will be something called prior authorization requirements, which is a way that the insurer gets to kind of weigh in and approve or disapprove a service before it is provided to the patient. So the provider's office typically is the one to contact the payer and say, patient, we think patient needs this service, please approve. And there's a whole process set out in statute for how that has to work and timelines and how that process gets turned around. And there was a lot of testimony taken last year from providers, payers, and others. And so what ended up enacted was saying, except in certain instances, a health plan shall not impose any prior authorization requirement for any admission, item, service, treatment, or procedure, so pretty much anything, ordered by a primary care provider. And then there were some exceptions, doesn't apply if it's being provided out of network. And then we had a definition as used in this subsection when we said no prior authorization if it's ordered by a primary care provider. The legislature said that has the same meaning as is used by the Vermont Blueprint for Health, which does a lot of work with primary care medical homes and primary care providers. All right, so that's where we got to where we are today. Let me take this down and put up the bill we're going to look at. So there were some issues that were identified since the legislature adjourned that this bill we're going to look at next is trying to address. Let's share this one.
Woody.
We addressed this something like 6 years ago when I was first in.
There have been a number of changes over time. Prior authorization in particular has been a topic of conversation for as long as I've been working in this building. Yes, it is there are different perspectives on whether, when, and how it is appropriate or not appropriate. And legislature has been trying to find the right balance on that for a long time.
And I will just say that I think a lot of this is that we actually don't have a definition of primary care.
Well, I think, was your question about the definition of primary care provider or the definition or when prior authorization?
Prior
authorization has been a perennial issue. All right, so here's the bill that is looking to address some, I would say, sort of clarify some questions that came up since the end of the last session. And so the first section here deals with that section on claims edits. And we said when we looked at that language, adherence to those specific claims edit standards that are largely around alignment with Medicare for a lot of types of services are not necessary. And we said when you have to comply with state or federal requirements, or if their process is followed and there are edits that the payer determines are more favorable to providers than what would have been. And then here's the new ones. Here's your underlying language. That's what's being proposed to be added. And this would say those claims edit standards do not apply when adjudicating claims for healthcare services that were delivered outside the state of Vermont, unless the payer and the out-of-state provider agree that one or more of those specified edit standards will apply. So in general, we're not able, for the most part, to enforce Vermont law outside of our borders. So this is kind of consistent with that, but clarifying because we do have Vermonters who receive care inside and outside of Vermont, and we have payers that are based inside and outside of Vermont. That when we're talking about a service that was delivered by a provider outside of Vermont, Vermont's claim edit standard requirements don't apply unless the payer and provider agree that they do.
Leslie?
Is that something that's negotiated by each claim, or is there an overarching agreement?
I would expect it's in the agreements between the payer and the provider
Yes,
more
contracts.
generally.
Okay.
Right, so,
There are contracts like for nursing homes and stuff like that.
right, it would be negotiated between the individual, either provider or a system they're part of, like a hospital, and the payer, but it wouldn't be on a claim. It typically wouldn't be on a claim by claim basis. I mean, the way the language is stated, it could be, but effectively what it's saying is we're going to keep Vermont law out of other states, which is kind of the way it works anyway. But look, if the payer and the provider out-of-state provider want to apply some of these standards, they're free to do so. All right, section 2 is looking at that prior authorization language. And as you can see, now not underlined because it was enacted last year, says the health plan cannot impose a prior authorization requirement for anything ordered by a primary care provider. But down here in the definition of primary care provider, it became clear in implementation that there wasn't necessarily a commonly understood meaning used by the Vermont Blueprint for Health. So this instead would put in a definition for purposes of when prior authorization is or is not allowed for a primary care provider to mean a healthcare provider who is contracted and enrolled with the health plan as a primary care provider. So the health plans know who they have contracted with. And since this is directed at the insurers, we're saying if you contracted with them as a primary care provider, then you don't impose prior authorization requirements on anything they order. And just for a little context, the definition of healthcare provider for this whole subchapter is already limited to Vermont licensed providers. So we don't have to have language in here saying this also doesn't apply out of state because we've already said that.
Any questions?
Yeah,
Oh,
so this means if there's an independent provider, they do not have to go through the prior authorization.
If they are a primary care provider and that is how they are contracted and enrolled with a health plan as a primary care provider, there should not be a prior authorization requirement for anything that they are ordering for patients covered by plans we regulate. So remember from Nolan's overview that only that subset of plans that the state can actually regulate. So that's the universe of people we're talking about here. But it doesn't matter if they're an independent provider or if they're affiliated with a hospital or other facility. It's the type of provider, the primary care provider part, that affects whether they are eligible for the prior authorization exemption.
and I think we're gonna hear from some of the payers and maybe they can explain like how this is in practice in real life. Is that okay?
Yeah.
Okay.
Right, and that's basically it. The first section on the claims edits takes effect on January 1st, 2026, when the provision it relates to takes effect. After you the former legislature, delayed the effective date. Section 2 on the new definition of prior authorization, primary care providers for prior authorization purposes would take effect on passage and be implemented by all health plans as soon as reasonably practicable after that date, but in no event later than January 1st, 2026. You'll probably hear from the providers about that and others. And then the effective date section itself takes effect on passage, so the other ones will work.
Any questions for Josh?
How does this affect the insurance companies?
They will tell you. I will not.
All right, so thank you. We're gonna move since we had sort of our health insurance 101. This morning, I wanted to bring in some of the health insurance to introduce themselves to us all, kind of give us an overview of what they do in our state and what role they play. And the reason I had Jen do this walkthrough, that I thought it would be a convenient time to maybe we could ask them how they feel about this piece of legislation and not have them coming in and out all the time if they happen to be here anyways. So if we want to start with Sarah from Blue Cross Blue Shield.
Thank you. I can't pull it up on the screen, but I did send a healthcare at a glance overview that I had sent to every member of the legislature. If you could pull that up. I was going to start with just the overview and then talk specific to the bill, if that's an okay approach. Okay. Great. So my name's Sarah Teachout. I'm the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. I have been with the company for about 7 years, shockingly. You know, when you try and think about how long you've been doing something. Prior to that, I worked for the Legislative Joint Fiscal Office here for 16 years, doing tax and policy analysis. So I'm pretty familiar with what you do here in the building. Oh, okay. Sorry, I can't. My computer won't let me do it. So I'll just talk to it. So I shared with you a document at a glance about Blue Cross and Blue Shield of Vermont, just to give you a little bit of an idea about, you know, our company and what's a little bit different about Blue Cross and Blue Shield of Vermont. So we are one of 34 Blue plans. We are a local Blue plan. So I think a lot of people think that the Blue system is one big company. It actually operates a lot more like a franchise. We are located in Berlin, which is just up the hill. We have about 400 Vermonters working for us. And that's where all the decisions are made about our health plans and coverage here in the state of Vermont. We did recently become a subsidiary of Blue Cross and Blue Shield of Michigan. We did that last year. One of the reasons we did that is to achieve some economies of scale, which we don't really have here in Vermont. So it enables us to access technology, have vendor contract relationships at a much larger scale. Blue Cross and Blue Shield of Michigan, just so you know, has about, I think they have 5.1 million members. We have about 228,000 members. So we really are talking a different scale. We have 400 employees. They have about 3,000 employees. So we've been able, we're still in the beginning of the relationship, but we've been able to leverage some of what they have to make us a little bit more efficient. So that's what we've been trying to do with that relationship. And I think one of the other things, we are a nonprofit, and Blue Cross and Blue Shield of Vermont offers health insurance in every single one of the marketplaces here in the state of Vermont. That makes us a little unique. And so it was really helpful that Nolan went through the list. So we offer Affordable Care Act plans to the individual and small group. We offer the large group fully insured that you were talking about this morning. We also offer self-funded health plans. So TPAs, ASOs, ERISA, whatever you want to call them. We manage those plans for employers here in Vermont. And then we also have Medicare supplemental insurance, Medicare Part D insurance, and Medicare Advantage. So we really cover the full spectrum of the marketplace here in Vermont. Trying to think of what else I wanted to hit upon.
Maybe I can ask you really quick is Blue Cross Blue Shield of Michigan also nonprofit?
Yes. Yep.
Okay.
Yeah. The only for-profit Blue plan is Anthem, and they are the largest in the system. So they went for profit. I can't remember exactly 10 or 15 years ago, they made the decision to do that. The rest of the Blue system is nonprofit. I guess I should say that. So, because this becomes important when you start talking about these bills. So Blue Cross and Blue Shield of Vermont, through our agreement with the other Blues plans, we contract with providers only in the state of Vermont and one county over along all the state borders. So that's our kind of service area, if you want to consider that. We also only sell health plans to companies that are located here in Vermont. We cannot sell health insurance to a company outside of our state. So that kind of necessarily makes us pretty small, because that's a pretty big limitation. Yeah.
Sorry, yeah. Is that a Blue requirement or is that a state statute?
It's a Blue requirement.
Okay.
Yeah. So to be part of the Blue system, and I think it's so the companies don't all compete with each other.
Robert, did you?
You cover, make sure, maybe I'm wrong, but you cover services that are provided at Dartmouth Hitchcock, don't you?
Yes. And we are contracted directly with Dartmouth Hitchcock.
Okay, that's not okay.
And then the other way that people who have our insurance can seek care across the country, in Canada and internationally, is our relationship with the other Blues companies. So we have a relationship, it's reciprocal. Our members can go to doctors who are contracted with a Blues company anywhere in the country and get the same care. They process the claims for us and then we pay them. And likewise, someone who lives in California comes to Vermont, they have Blue Cross Blue Shield of California, they come here, and we pay the claim and then send it back. So the way it operates is a little bit different than most other kind of national insurers. So I think that's important.
I wasn't aware that you included in your products is indemnity. Can you talk a little bit about how that functions?
Oh, gosh, I wasn't prepared for that question. Let me find out more for you, because I'm, there's a lot of products that we have. And we do have 2 subsidiaries of our own company, the Vermont Health Plan and then Cobalt CBA Blue. So we have some subsidiaries here in Vermont, but they're pretty small. So those were the high level things I wanted to say about kind of Blue Cross and Blue Shield. I'm happy to talk more specifically about.
I'm curious about your Medicare Part C.
Yes. Okay.
It's my understanding that that's a relatively new, I mean, in your history, a relatively new market
Mhm.
for you. How many years have you been?
4 or 5.
4 or 5?
Yep.
Do you have the numbers? So you give, so you have 30,000 Medicare members. Are those inclusive of your Medicare supplements?
Right, great question.
Or are those strictly Part C?
So I should have said the data on that sheet is 2023 because that was the last year I had full years for. So I should have updated numbers for 24 really soon, and then we're headed into 25. Just to say it out loud, Medicare Part C is Medicare Advantage.
I'm sorry, is that clear to?
Yeah, and it is a relatively new market for us. Blue Cross and Blue Shield of Vermont partnered with Michigan before we entered into our affiliation with them to enter that market here in Vermont, because starting a new health insurance product requires a pretty substantial capital investment. And they also had experience in that marketplace that's a little bit unique in the way it runs. If you ever want to talk about Medicare Advantage, we can talk for a long time about how it works, but it's a different kind of marketplace. So when we started, we were 50-50 roughly partners with them. We have since divested maybe our share. So we're down to 15% share in that market because of the risks that are currently going on in that marketplace. There's a lot we could talk about, but I don't know if you know, most of the carriers exited Vermont. And there are very few left. So we've had a huge influx of new members in that product. And there's a lot of risk with that kind of change. So we've changed our relationship with the plan, but we still have some investment in it.
Just for clarification.
No, why don't you go ahead and then I'll.
I just wanted to clarify because sometimes pronouns confuse me. Yeah. So what are you referring to? So you're saying you have 15% market share of Medicare Advantage. So when you're talking about that, what are you talking about?
Right, not market share, interest in the company. So Vermont Blue Advantage is a separate company that only sells Medicare Advantage plans for us here in Vermont. And like I said, we were roughly 50-50 when we started with Michigan. Now we're down to 15%. And that's new. It's at the beginning of this year. We had very, very tiny market share when we first started Medicare Advantage in Vermont, and it grew extremely rapidly. So
can you talk about that?
sure. So when we entered Vermont, United and their product was the most common Medicare Advantage plan. It's sold by AARP, which is, one of the reasons to buy it. And then I think I can talk about it, but the marketplace has changed a lot, the financials of it. And so I think all except for 2 carriers pulled out of the state of Vermont. So a lot of Vermonters for Medicare Advantage.
Okay.
So a lot of Vermonters were forced to shop. That means they lost their coverage that they had chosen when they turned 65, and they were forced to pick a new plan. And it triggered a special enrollment period. So they could choose anything they wanted. They could go back to a Medicare supplement plan. They could, choose a different Medicare Advantage plan. And many of them chose the Blue Cross Blue Shield Medicare Advantage plan. I think we've had a dramatic increase in the number of people enrolled.
Do you have any data?
I think we're still waiting for final data on everything,
Yeah, I'm just curious to know the comparison between Medicare Advantage and original Medicare in terms of supporting subscribers in, what's denied, what's not denied. How does that work?
Sure. I was going to say there's price data out there already.
Yeah, I understand about that, but I'm thinking more about people.
Coverage and
Yeah, what's being covered, what's not, what are the surprises that are coming for subscribers?
Sure. I'll start out by saying, Medicare Advantage is a different product. The differences between Blue Cross and other carriers are pretty dramatic in their coverage. And then we've tried to be very similar to what we cover in our med sub plans. So our network, for example, is almost identical. But there are certainly differences.
I'm curious about if you can talk about some of the self-funded plans, because we looked at the pie chart, and we know a lot of the self-funded plans, and those are really important groups some of them in Vermont. But I'm also, I don't think I've quite ever really understood the relationship that Blue Cross of Vermont has, Blue Cross Blue Shield of Vermont has with Blue Cross Blue Shield of Michigan. Is it, I mean, is the risk pooled?
Yeah, good question.
Or is it that you're more just sort of a sub-franchise underneath?
It's the second. We're a subsidiary of Michigan, but everything that we do is a self-contained Vermont only plan. We're not sharing capital with them, with a recent exception. We don't share risk among our pools. Our plans are completely different. It's partly because health insurance is so unique to every state that Michigan can't just walk into Vermont and sell health insurance. And there's a lot of rules about how we share risk here in Vermont. So no, we really operate in the way that we're giving our plans out and designing everything very much like it's almost identical to what we were doing before. What's different is our back office, which is the stuff you don't see, but our, contracts with our pharmacy benefit manager, our operation of our NASCO, which is our claims operating system. Michigan owns NASCO. And so we were, now we all own the same system and we're able to use their IT support and get kind of others economies of scale. They're very, very big plans. So they have a lot more leverage in the industry than we do.
And you just sort of pay them kind of franchise fee in a way, or?
No, we don't pay them anything at all.
Right.
I think there's a recognition in the insurance industry, and I'm getting a little far afield here, that scale is meaningful in making you more efficient. And we've seen that kind of all across healthcare, not just insurance, but everywhere. Companies are joining together to achieve bigger scale. And so we're doing that in a way that keeps us continuing a Blue plan, and sort of the Blues, I think, philosophy would be the way to say it. We're a different kind of health plan, and we wouldn't merge with, some of the other national for-profit players.
I can see the advantage, obviously, to Blue Cross Blue Shield of Vermont. What's the advantage to Blue Cross of Michigan? What are they getting out of the
So
relationship?
they're also a single state Blue plan, and I think they're looking for ways to, to grow and to be, move into the new century with healthcare and health insurance. They're a much bigger organization, and they have businesses in different kinds of industries that we don't have. We only sell health insurance. The Blue Cross and Blue Shield of Vermont, they sell stop loss. They have some other types of businesses. So I think it's a way for them to expand their footprint. And I think that they would like to be a bigger health plan as well. So we're maybe like the first step in that direction.
My last question, because you had talked about how as a Blue, you can only insure people and employers in your state and then counties around. Are there regions in the country, other regions where states have in the same region have pooled together? I mean, I'm thinking about things like, why is there not a New England Blue? New Hampshire, Maine, Massachusetts.
There's a lot of history here. So there used to be a Vermont, New Hampshire Blue plan
Okay.
way back. I think you all remember. And Vermont separated from that plan. And then the New Hampshire plan became Anthem, or was purchased by Anthem. I don't know the exact history. So Anthem has some of the New England states. I don't want to say most, because they have Maine and New Hampshire. Massachusetts has its own Blue plan. New York has several Blue plans. They have more than one. And so I think there's a difference in your question about asking how the Blues do it and how states do it, right? So I'm not aware of any state that pools health insurance with another state, but there are Blues plans that are multi-state operations. So Anthem is the
Not just Anthem, but others.
Yes, there are. There's one called HCSC, Healthcare Services Corporation. They have a lot of the states in the West. Regents has the Northwest. I There's more, but there's a few really big ones. And then, examples of single state blue plans are Blue Cross and Blue Shield of Michigan, Florida Blue, North Carolina Blue, Horizon, and New Jersey. So there's some pretty sizable single state blue plans.
And to go back to if I was hoping you could talk about self-funded.
Yes.
Yeah.
Sorry, I already forgot.
That's it.
Um,
I had two.
So sure, we're not the only player in the self-funded marketplace. There's certainly a lot of competition for business when self-funded employers are looking for, you can call it a TPA. So we have some of the largest employers in Vermont. So we have the state of Vermont employee plan. So that's pretty significant. And we also have VHI, which is the Vermont Health Education Fund. It's a little bit different. It's a little bit of a unique plan, but it is technically self-funded. And that's all the school districts' money pooled together. We also currently have, say, the University of Vermont Medical Center as a customer. So they are quite large. Those are probably the biggest self-funded plans. I think the other thing that we see a lot is companies that have some employees here in Vermont, but are headquartered somewhere else. So for example, I know Hyatt Hotels has employees here, but they're based out of Illinois. So they have Blue Cross and Blue Shield of Illinois. So we process the claims, and I think a lot of them think they have Blue Cross and Blue Shield of Vermont, but they don't. Is there something else you were looking for on that? I guess the other,
I did want to, in terms of Medicare Advantage. So if I'm a teacher or a state employee, and I'm retired, because those are self-funded plans, are those retirees then in
that's a great question. Medicare Advantage.
Medicare Advantage?
So the teachers are and the state employees are not.
Okay.
And the other thing I would say, I should have said it up front, in Medicare Advantage, there's group Medicare Advantage plans and there's individual Medicare Advantage plans. So the individual ones are the ones people are purchasing that you see advertised on TV. And then the group ones are the ones that their employer is sponsoring the plan, and we design the plan specific to that employer. And so oftentimes they look different, and the employer is funding that Medicare Advantage plan. So some employers are choosing Medicare Advantage, some are choosing other types of med sup plans. And then a lot of employers don't offer retiree healthcare. But because healthcare is extraordinarily expensive, especially for retirees, I think a lot of them are looking for different options. Nolan said several times this morning that self-funded plans, that we don't take any risk for self-funded plans, and that's not totally true, but it's far diminished. So we take the risk that we're paying their claims and then the company needs to pay us back. And we do hold some capital reserve that a company went bankrupt or decided not to pay us or something else happened. So there's a little bit of risk on self-funded plans, but the majority of the risk is with the employer.
And I did have a constituent question actually very recently. So for the teachers specifically, their retirement benefit, they've been moved to Blue Cross Medicare Advantage.
Yes,
I believe they used to have Medicare Supplement.
they did.
Is there an option left anymore for the retirees to say, I'd like to stay with my traditional Medicare with my Medicare Supplement? Or is everybody now on Medicare Advantage?
I'll have to ask. I can't remember. That's the choice of the employer. And I can't remember what they chose for the teachers. Yeah. I think the other thing I wanted to mention in the chart that I handed out was in that I'm showing you 2023 data, and there's a graph that shows how much we pay out for medical claims, medical and pharmacy claims. Then there's how much the cost of administration is for our plans, and then how much state and federal taxes and fees are. So you touched on this morning. Blue Cross and Blue Shield of Vermont has some of the lowest administrative fees of any health insurer nationally. It's at 6.2% right now, and the vast majority of our claims or our expenses are just paying people's claims. You will see that in 2023, for every dollar in premiums collected, we paid out $1.11. That's not optimal. Right? So, and I could spend a lot of time on the process or not, but and I like to compare it to how you do budgeting here in the legislature. So you have your state economists, I think next week coming in, and there'll be a consensus process where they determine the amount of revenue that you'll have to spend on your budget for next year. That's really parallel to what happens at the Green Mountain Care Board with premiums. So our actuaries come up with an estimate of how much they think the expenses are going to be for the projected number of members that we're going to have at our company next year. The Green Mountain Care Board hires a national consulting actuarial firm called Lewis and Ellis. They review our filing and they make recommendations for changes, usually very technical, and say, you should change this assumption or that assumption. It's actually a very collegial process, and usually there's agreement, partly because when we file in May, there's a lot of things we don't know that we learn in July. So it's an iterative process of getting a more accurate estimate. The other thing that happens is we're very explicit about the amount of margin that we want to make on our premiums. So we ask every year for 3%, except for this year. We ask for 3% margin. And what we're supposed to do with that is put it into our reserve funds and save that, because we know that we're never going to be 100% accurate in what we're estimated. So the other thing with insurance is you all come back and do the budget adjustment every year and say, we missed with this and we're off with that. And we have more people on this program and we're going to do a budget adjustment and fix it all. We can't do that with premiums. So we decide the premium that we're going to charge in January, and we have to charge the same premium for the whole year. If we're under or over, we can't adjust. So in a normal course of events, some years would be a little over, some years would be a little under, but you don't want to be really over or really under. You want to be kind of in the middle. And that's what reserves are. One of the reasons we have reserves, so that if we missed and we underestimated or overestimated, it would go into our reserves. What's been happening is that we are, I want to say it the right way, underestimating the amount we need in premiums consistently. And so what we're seeing is a drawdown of our reserves year over year.
That where you're getting that 11 cents from?
Yep. So when we have to overpay, we don't have any other source of income as an insurance company, except for investments. We take that reserve fund, it's invested and we make some money. So part of the reason that we only ask for, and I know only 3% for contribution to reserves every year when medical inflation's growing faster, 6, 7, 8, even higher, is that if our investments are good, we can offset some of what we need with investments on Wall Street and charge Vermonters a kind of a more consistent amount.
So you have your chart for 2023.
Mm-hmm.
I realize that you're not done completely with 2024, but is there an estimate on 2024?
2024 was worse.
It was worse.
Yes. Yeah.
What was a sense of 2022? What was 2022?
I think we've lost money in 5 of the past 6 years. So, generally it has not been, it's always been under, rather than being under and over like you normally would be, it's been under every year. There's a lot of reasons for that, a lot of history to it. Recently, we've just seen an explosion in costs, and that was the other chart I gave you. I showed since 2020 I had it through August 2024. This is just pure how much we spend on our members' claims every month. And you can see that they're growing at a really fast clip. So, double digits.
Do you have I'm looking at that chart. Do you have a sense of what that's made up of?
It's a lot of things coming together, but we believe that a lot of it, we know a lot of it is the charges, the prices of hospitals. So we've had some pretty significant hospital price increases in recent years. I noticed that Boz showed you what was approved. But the other thing that's happened is for the last several years, the Green Mountain Care Boards have approved a hospital budget and a hospital commercial rate, and then the hospitals have gone over that budget. So that's money that was not anticipated and certainly was not built into premiums. So that's one of the reasons that the premiums have fallen short.
Did you have a question, Leslie?
Well, I sort of do just by its extension. I'm just thinking about actuaries. So have the actuaries just not understood the population, or were the changes coming from outside their understanding of the system?
Yeah, so it's not really the actuaries. They're doing their best to estimate, and it's national actuaries and local actuaries. I would say our local actuaries probably know the Vermont market, and the national actuaries can kind of see the big picture. So it's actually really good to have those two perspectives. For a long time, the Green Mountain Care Board would set a premium that was maybe lower than even the actuaries were recommending. You'll hear this, I did work a long time on a state revenue forecast. When they do a revenue forecast, the economists will tell you that there's ups and downs along all the tax types, right? Income tax could be up, corporate tax could be down, insurance premiums tax could be up, and the forecast is a mix of all of those things. But you would never choose the highest or the lowest assumption across the board, because then you would definitely be wrong. Right? So they're trying to pick the most accurate assumption. They're not picking the highest or the lowest. And what the Green Mountain Care Board was doing for a very long time was picking the lowest assumption. So we're going to assume the lowest trend for healthcare, the lowest trend for pharmacy costs. And then on top of it, we're not going to give you the 3% margin that you're asking for. We'll give you 1.5% instead. You just can't keep up with medical growth if you're making assumptions that aren't realistic. So that was happening for a long time. So our reserves have been declining for a number of years. It's not new. But what's new is hospitals going way, way over budget and prices being pretty high.
I was just gonna ask,
You might not have wanted all this, sorry.
this is naivete on my part. I mean, we heard from Voz the other day, and if a hospital is approved for a certain budget, certain revenue, and if they're over and you're dipping into reserves 11 cents out of every dollar, do they ever have to give you back?
So this last budget cycle, at least a couple of the hospitals that went over, the Green Mountain Care Board cut their next year's budget to try and kind of move it back in the other direction. So the University of Vermont Medical Center, for example, had a 1% budget cut. It was half of the amount that they were over. So,
But they never say you collected too much, give it back to Blue Cross Blue Shield.
they haven't done that yet.
Okay.
They've done other things. One year, they asked the hospital to invest in affordable housing. Another year, they asked them to invest it in the mental health facility here in central Vermont. So there have been overages for a number of years and different decisions made at different times.
Woody, did you, well, I think Woody had a question first. And that. Okay, Jay-Z.
That hospitals are over.
I'm being broad in that definition, but yes.
In Vermont, are all hospitals over budgeted, or are there certain hospitals that you're claiming?
It is certain hospitals and it's different ones in different years.
And you can't share that with us, I guess.
It's on, I could pull it up. It's on the Green Mountain Care Board website. Every year, what the approved budget level was and then where the hospital ended the year.
It's kind of funny because, well, it's not funny. Green Mountain Care Board sets what the hospitals can raise, and yes, the Green Mountain Care Board is not enforcing those requirements that they set each year, or how would you?
So they have had enforcement actions.
And what type of enforcement actions do they, fine or?
Yeah, no. So, I could look it up for you, but one year, I think the University of Vermont Medical Center, at least 2 years, the University of Vermont Medical Center was over. One year, they asked them to invest the overage in affordable housing. up in Chittenden County, and I believe they did that. Another year, they asked them to invest that money in mental health care in a mental health facility here in central Vermont. There's a long history behind that. And then in some years, they've asked them to lower commercial rates. And not just UVM, but other hospitals have lowered commercial rates in either the year they're in or in a subsequent year because they were collecting more revenue than they were allowed by their budget. Now, budgeting is just like actuarial forecasting. You're never going to be perfect. So there's going to be some over and under in other years, but the idea is not to be way over or way under. That's where you get into trouble.
And recently, media, it's been claimed, or tend to remember that UVM was quite a bit over budgeted this past year. And I may be wrong, but the Green Mountain Care Board said you must reduce your budget.
Your commercial rate
Okay.
by 1%
Right.
was the end result.
And as a result of that, we have that effect upon other hospitals. With services maybe being cut that were affiliated with UVM. Is this all tied together?
It is all related, yes.
So like in my community hospital, the dialysis system has been looked at and may very well close. UVM, as a result of this, have said, we're going to go to New York State and do more business there, I guess. So this is all related.
It is all related, and there's, a lot to dig into to get the real facts behind all of these different things. I think one other thing I wanted to come away with, because, we're hearing a lot, well, why are costs so high, healthcare costs? I'm telling you, it's hospital prices at hospital budgets, but you should dig in and look, what are the real reasons? You've heard that it's demographics. I think you're hearing that it's shifts from Medicare and Medicaid. There's a whole litany of things that it's being blamed on. On the demographics piece, I would just say that for our members, we cover, the chart I gave you is people up to age 65. That's the vast majority of people who have commercial health insurance. So we're not seeing that like big growth in older population on our plans, except for on the retirement plans. We've actually seen the average age of people who have regular commercial health insurance with Blue Cross has gone down in the last year. We think we're not 100% sure why. It could be new people moving to Vermont. It could be the Medicaid redeterminations. There's a whole host of reasons, but the aging is not affecting the vast majority of the people on Blue Cross plans.
I want to go back to some of the nature of Woody's questions, because
These are important questions.
yes, and I know we're going to revisit them many times this session, but knowing what you know about what we do in this building and the disaster that our healthcare system and hospital system is in right now, we're all deeply concerned. And looking back, what could we in this room and building done 5 years ago to have prevented you from being in the financial situation that you're in? Because I'm hearing that your reserves are almost gone. You're our biggest commercial payer in the state. For those of us in the room that have insurance, you probably insure the majority of us. I am scared, and a lot of my residents in Winooski are scared. So what could we have done as a legislature 5 years ago to prevent this?
Yeah, you're asking great questions, not easy ones to answer, obviously. And I don't want you to be scared, because we really are doing everything we can to ensure that we'll be in a financially stable place. That's part of the reason the rates went up so much this year. Instead of a 3% contribution for reserves, we asked for 7%, and the Green Mountain Care Board granted it. Now, that wasn't easy for anyone, and we know that, that's really tough on Vermonters, but that's intended to get us in a better financial place. I don't think a 1-year fix is going to do it, but, we're working on it. We're also working with Michigan to try and be more efficient and save more money. On that end, we've cut our administrative expenses, but that's part of the reason I showed you the chart. There's only so much you can cut. It's not the biggest piece of the pie. But as you've done that here in the legislature when revenues have been tight for the state of Vermont. You've had to cut state government. So all of those things. I don't think there's one thing you could have done. There's like lots of things that could have been done differently. And it's really hard to say, was there one thing you could have done to make it better?
Ari?
Two questions, what can we do now? But also I hear about the increased burden of prices from hospitals. Are pharmaceuticals still the drastic increase in pharmaceutical prices also part of the problem?
So pharmaceutical prices are always part of the problem, yes. I think that they've been eclipsed a little bit by what's happening with medical prices here in Vermont. And then just to say it, it took me a while to figure it out. There's two ways that you get drugs. I'm sure you know this. There's retail pharmacy drugs. So you get your prescription from your doctor, you go and you buy it on retail, and then you get administered drugs in the hospital. Those are two completely different paths, and they function very differently in their different markets. And we're seeing really, really high prices for the drugs that you're getting via the medical side as well. So that's actually, that's where we're seeing the biggest growth in drug prices, at least at Blue Cross.
What is what's the origin of the increase? Is it from the PBM, from the manufacturer, or from the
The
hospital?
markup at the hospital. So.
I'm sorry, I didn't mean to interrupt you, but I want it because
I know you want me to comment on the bill and you have other people waiting, so I'm sorry.
in the line of question and the chart, it would be really helpful. And I understand you don't have it here or can get it to us, but maybe in the near future, can we have sort of a breakdown of, I don't know, a pie chart or something where costs are going up, where costs are remaining stable? I mean, that's pretty alarming what I think you just explained to Mari.
Sure, and that's what we do for the Green Mountain Care Board every year, so I can.
That would be great if we kind of get that data, just so we can look at it on a much more granular level to get a good idea of the whole picture.
Okay. The last thing on that chart, just I wanted to say, is the dark blue line is the costs. This is where it was important to know about Blue Cross. It's the cost that we're paying to the providers that we're directly contracted with. So it's Vermont and, one county and along our border. Along the very bottom, it says Blue Card, which is, I tried to get our team to change it. It's sort of Blue Cross lingo. But Blue Card is cost for our members that we're paying when they go anywhere in the Blues network that's not directly contracted with our company. So that's people going to Boston, to California, anywhere they're seeing care. You can see that the costs there have not grown at the same pace. So what we're seeing here in Vermont, we really believe is a little bit unique to what's happening. And I'm going to move on because I know you wanted me to comment on the bill, but I
see that our ledge council just walked out of the room, but I think that we can probably, I mean, if you had comments about it, if there's, and I can take notes as to
it's not that involved.
any changes, or maybe I follow up and have any changes.
No, we
suggest.
We support the draft bill, the changes that you've made. I think that either the PCP definition that's in statute now, which limits it just to PCPs participating in the Blueprint program, works for us because there's a list of those PCPs over at Blueprint and we know who they are. It's updated every month. And we just really need to key off something that's, current. Doctors move in and out of the state all the time, and it has to be a list that we can use. The same with this. So this is a list of providers who come to the insurer and say that they want to be contracted with us as a primary care physician. There's different requirements than for specialists and others. And so we have that and maintain that list all the time, and we know who those are. What we really didn't want was some different list that's not already in use. So this works fine for us. And then the last thing I would note is the effective date. Says that you would like us to do it before January 1st, 2026, but allow us the time. We really do appreciate that. It was a fairly substantial technological lift to get all of this stuff into place. We're still, working through issues and, getting providers to understand the system. And, it's a little bit of back and forth finding bugs. And so we'll be working through that for a little while. And we didn't want to be forced to immediately try and change to a whole new system too quickly. So I think we believe it's easier for everyone to have more of a anticipated process for change.
And because I know, we worked on the language.
Mhm.
I just want to be clear. You're okay. Blue Cross Blue Shield is okay in the future. And I understand the implementation because you have just implemented the blueprint. One.
Definition, yep.
These are providers that have come to Blue Cross Blue Shield of Vermont and said, I would like to be a Blue Cross Blue Shield of Vermont provider, and I would like to be a primary care provider.
Correct.
And you're fine with that?
You're fine. It includes a few more providers than the current definition does. For us, it's roughly 200 because there are providers who contract with us as primary care providers, but are not participating in Blueprint. And so you are scooping in more primary care providers, which I think is the intention.
Yes. All right.
Thank you.
Thank you, Sarah.
Yep.
Thanks, Sarah. So we have with us Jordan on Zoom, Jordan Estee from MVP, and welcome.
Thank you. Good afternoon. Can you hear me all right?
Yeah.
Great. So I think I'll start with the bill, if that's all right, and then move into kind of an overview of MVP, just to pick up on Sarah's comments.
Sure, I think that's a great plan.
So MVP supports the bill as well. We were engaged in a lot of the stakeholder conversations since the bill was enacted, last session, over the summer, into the fall. The claims edit section in particular is important to MVP, incredibly complicated. When I go over MVP's footprint, this will make sense, but MVP is a small regional plan that operates in multiple states. So, we identified a challenge when we were implementing this, that because of the claims edit requirements are in the insurance law, so that deals with members' insurance benefits. Technically, it would apply if an MVP member in Vermont visited Albany Med in New York, right? And at a high level, that would be impossible for a small regional plan like us to implement that across our whole network, for Vermont, for our Vermont population. So really appreciate that distinction, that clarification, and fully support that. Like Blue Cross on the definition of primary care provider, we've implemented it today to key off the blueprint list. We are agnostic on which approach the legislature decides to take, whether it's sticking with blueprint or moving to the definition that's included in the bill. We can make either work. I think that's really a policy question because there's pros and cons to each. I think the con for the blueprint approach is that not every primary care provider in our network is participating in Blueprint. But on the flip side, a policy con for the approach in the bill would be that there's a possibility that Blue Cross's primary care list and MVPs are not the same. I think they're largely going to be the same, or close to the same, because we both have very robust networks in Vermont, but that is really a policy question. So any question about MVP's thoughts, feedback on the bill?
No questions, right? Yeah. So why don't you introduce us to MVP?
All right. I'm going to attempt to share my screen. I have some slides which were submitted for the record as well. Can you see my screen all right?
Yep.
Okay. So I can't see any of you. So if you'd like to interrupt me, please yell out and ask questions or whatever. So MVP Healthcare, I think importantly, just some background, we were founded by a group of physicians in the capital Albany region of New York State in 1984. So MVP actually originally was Mohawk Valley Physicians Health Plan. Over time, we've expanded our footprint really to be all of upstate New York and Vermont. So we are a regional not-for-profit health plan. So not-for-profit like Blue Cross, but regional in the sense that our footprint extends, across multiple states, multiple local geographies. So as a not-for-profit plan, a community-focused plan, we are very mission-driven. And as part of that, really, as part of our mission, it's really to be there in the community with deep relationships with, hospitals, local providers, community organizations, and other stakeholders to really help improve and manage care for everyone throughout our community. So, in Vermont, and I'll get into this on the next slide, we're only in the exchange QHP markets, but in New York, we're actually heavily invested in what we call government programs. So more than half of the 600,000 enrollees we have are in Medicaid, Medicare, child health insurance plan programs, and we're also in the commercial markets as well. So again, having that kind of broad focus and community focused mission. We've got about 1,500 employees across, our footprint in headquartered in Schenectady. We've got a Williston offices in the Hudson Valley of New York and out in Western New York. And, I'll just point out here because, this comes up in a lot of the national conversations. It comes up in conversations with my family and friends, right? Whenever, health insurers are talked about in the abstract, I think there's a general misunderstanding of who we are and what we do. So, our workforce is really comprised of a whole range of people with clinical backgrounds and specialties, from physicians to pharmacists, nurses, therapists, social workers, actuaries, health economists, and people that are really engaged at the local level throughout our communities. And the not-for-profit distinction really is, we're not publicly traded, so our mission, our day-to-day focus is not on increasing revenue or increasing profit for the benefit of a stock price, but rather, really investing in our local communities. Now, we have to make a profit in order to keep the lights on, but, all of those profits are reinvested back into the business, whether it's going to reserves, as Sarah mentioned in her comments, or into new investments, technological capabilities, or other, services for our members. So Vermont specifically, we've been in the state since 1993, licensed as an HMO. We've got about just over 30,000 members here in Vermont. That number has grown a little bit heading into 2025. Our provider network is very robust and comprehensive. It encompasses, over 5,000 provider partners in New York and Vermont. And similar to what Sarah was explaining with their National Blue program, how when you leave Vermont, you can get services in another state. MVP we're not a Blues plan, obviously, but we have a similar arrangement with Cigna. So where if you're outside of our footprint, New York, Vermont, we're contracted with Dartmouth, Hitchcock, and some others in New Hampshire, you can access those services through our agreement with Cigna. So really that's intended to allow a smaller regional company like MVP to compete, on a larger scale with some of the national insurers. And, again, as a mission-oriented community plan, we take very seriously our presence in the communities. We see that as a differentiator. We know our communities, we have these relationships, and, people here are very passionate about that as part of our mission. Our membership, what I did here was take some of the information that I know Nolan shared this morning and he shared in the past about, where Vermonters get their health insurance coverage. So this breaks up the different coverage sources into the pie chart. And what I wanted to emphasize here is that MVP's Vermont presence is really focused on the individual and small group markets, which are about, 72,000 people. And we've got about 32,000 enrollees only in those two markets. So that's really where MVP is active in Vermont. We're no longer in Medicare. We have very minimal large group and self-funded business in Vermont. So again, those markets we're active in, our rates are approved by the Green Mountain Care Board. We're regulated by DFR. These are the ACA compliant products, and they're sold primarily through Vermont's Health Exchange. I did want to, call your attention to these two charts, and I'm going to leave you with some policy perspectives and priorities of MVP. I think they're interesting, and I think they're very relevant to a lot of the discussions we're having now and we'll be having in the future. The first chart on the left-hand side is from data, I think, that was presented in Nolan's presentation to the committee in 2023, which showed year-over-year enrollment trends in the different market segments. So this data only goes through 2020, but I think we assume that the trend has continued. And what you see there is that in 2013, the membership in the self-funded market versus the fully insured markets, so the state regulated markets versus the non-state regulated markets, were about 50, evenly split. And over time, you've seen a very significant drop in the number of enrollees in the state regulated markets, while you've seen a significant growth in the non-state regulated markets. So that is an important piece of information to understand when we're having policy discussions in Vermont, as to the limited scope of, state law, and the fact that, the impact is going to be limited to these markets, and therefore may have unintended consequences of making premiums, making coverage more expensive in these markets, causing people to look elsewhere for more affordable options. On the right-hand side, this is a chart showing the average total premium in these QHP markets, so the ACA markets through the exchange, between 2016 and 2023. And what this shows is that while premiums have been increasing too much, frankly, nationally, they've increased at they're even higher in Vermont, and they've been increasing at even greater rates. So I think in that kind of national analysis of the states, Vermont's like the 41st or 42nd in terms of premium affordability. And I'll leave you with policy principles and, that I'd like to share, and certainly welcome any questions. So, I would urge the committee to really, when we're considering and discussing, policy changes this year, to really focus on the cost of care, the unaffordable nature of health insurance premiums. That we're at a point right now where, too many people simply can't afford their health insurance coverage. And, the reality is health insurance premiums are expensive because healthcare costs are expensive. We would urge you to really take that into consideration, to be very careful about the cost implications of any policy change, regardless of good intentions. To the extent that we are making policy changes that have a cost impact, when we tend to think about cost at MVP or in the health insurance industry in general, a higher cost in and of itself isn't necessarily a bad thing if you're getting corresponding value from it, right? So you're improving outcomes, you're improving experience, you're improving the quality of care. That's an important consideration when we're having discussions about cost. Number two, I would urge the committee to really prioritize Vermonters at the center of these discussions. So I think I raise this principle because it's something that MVP talks a lot about in terms of where we want to go as an organization, is that the healthcare system is changing rapidly. And, we really all need to kind of think outside the box to advance a system that's, it's equitable, it's affordable, it's resilient and transparent, and most importantly, really built around, in this case, Vermonters' individual healthcare needs and experience. So historically, the healthcare system has been incredibly fragmented. You've got, your hospitals here, your pharmacies here, your health plans over here. And, that kind of fractured nature is not going to meet the needs of the healthcare system going forward. We really need to focus on, the individual patient consumer, and strive to design a healthcare system that meets their needs and isn't really targeting or, intending to support any particular industry, entity, or stakeholder group. And I include health plans in that statement. And number three, going back to, the charts on the last slide, really urge the committee to think about policy changes and be aware of that scenario that it has been happening, where Vermonters are leaving the state regulated health insurance markets in favor of, more affordable options, through either the self-funded markets or other arrangements. And be mindful that state law, I think, has a limited and shrinking reach on the private pay markets. And that state law changes primarily affect only the two local not-for-profit community-focused health plans in MVP and Blue Cross, are the only two plans in the QHP market. So I would leave you with that. And, I think it's obvious, but Vermont needs a strong and stable health insurance system. So happy to answer any questions, but really appreciate the opportunity to join you, to reintroduce MVP to a lot of those that, I've worked with in the past, and to introduce MVP as an organization to those new members of the community. committee.
Questions? I have some, but I'm gonna leave it to anyone else if they have. All right, well then I'll ask away. I'm frankly gonna ask you a lot of the same questions that
Sure.
I asked Blue Cross Blue Shield. So Medicare Advantage, if I recall, you previously had Medicare Advantage in the state of Vermont,
We did.
but I don't think you do now.
We do, as of this year, we no longer offer Medicare Advantage in Vermont. So MVP had been offering Medicare Advantage in Vermont for some time. I think we had small limited membership. In 2022, I believe, we launched with the University of Vermont Health Network, the UVM Health Advantage Plan. So that was pretty nascent in its history. So they're really only a couple of years into that experience. I think we were very proud of the work that went into that product, right? Partnering with UVM, the clinicians at UVM, to really take a deep dive on data to understand the healthcare needs of local Vermont seniors and design a product and a service platform that's really built around their, Vermont seniors' unique healthcare needs and experience. I think, as Sarah alluded to, a lot of things are happening in Medicare Advantage nationally over the last 2 or 3 years. That was a new product, a new partnership, where you expect to lose money in the first couple of years of any new business endeavor. But given some of the national changes that happened really last year and the year before, and then there's some unique Vermont elements of Medicare Advantage financing that if I could put it as simply as possible, the cost of care for this population in Vermont was far exceeding what CMS is willing to pay. So as a small regional organization, as a not-for-profit organization, we had to make the very difficult decision to exit that market in Vermont this year because we simply couldn't sustain those losses going forward.
Do you operate a Medicare Advantage in New York?
Yes. Yep. So and I don't want to bore everyone with the detail, but there's in Vermont, so Medicare Advantage premiums, so what CMS pays to plans that are offering Medicare Advantage are based on local Medicare fee-for-service costs at the county level. So the cost of Medicare for the average fee-for-service beneficiary in Chittenden County, there's that is kind of the basis of what they look at, but there's some arcane requirements in Medicaid Advantage, rulemaking and statute that say certain counties, the level of growth is basically capped at certain counties, and every county in Vermont has that cap in place. So where there's been significant cost increases in counties like Vermont has, frankly, the arcane CMS rules and approach here have really underfunded Medicare Advantage in Vermont.
And I thank you for that. I also you're in a unique position because you operate in, I'm just going to say New York and Vermont, but I'm sure that you have relationships with other areas. We heard some pretty alarming numbers from Blue Cross Blue Shield. Is MVP experiencing some of the same difficulties that in the last few, I guess I'm asking, how are you doing? How are you doing?
So yeah, the answer is yes and no. So no, in the sense that we are well reserved today. We don't have any reserve concerns, but yes, in the sense that, there's some very unique challenges in Vermont where we have also lost money in the limited markets we're in 5 out of the last 6 years. So I think last year I had pulled some of this information, and we don't have financial numbers for this year yet, but from 2019 through 2023, Blue Cross and MVP, so again, the only 2 carriers in these markets, had lost, I think, collectively around $80 million in those 2 markets. The only year we made a profit was in 2020, and that was the COVID year where people weren't going to the doctor as much, so we didn't have as much medical expenses to pay out. But even then, the profit wasn't, very significant. It was maybe a point or two. So, it's a scenario where, like Blue Cross, we have been losing money in these markets year over year, which, frankly, isn't sustainable. But I think, we certainly had, feel like 2024 was going to be a better year. And it looks like it's going to be a better year, but I think we still expect to lose money, not as much as we've lost in the past.
And do your reserves are they all, I guess, do you separate your New York and your Vermont markets and your, I don't know, for lack of a better word, your book?
So
Or
the,
are the reserves
Yeah,
strictly
the-
from Vermont, or are you using New
so
York?
the products themselves are licensed in Vermont, they meet Vermont laws and rules. And the rating all happens within the Vermont footprint, right? So, we don't factor in costs and experience of New York enrollees into the products we price and sell in Vermont. So they're really, the products are priced to the people that are purchasing them, and only people in Vermont can buy those specific MVP products. The reserve question, I don't want to get this wrong, so I'm going to state this as my assumption and understanding is that our primary regulator is in New York, and they look at our reserves at an enterprise level. So we're adequately reserved for our total book of business, so 600,000 members or so. But I don't think it's specific to Vermont, which is, again, 33,000 members. So a small slice of our overall business. But I think they look at our reserves at the enterprise level, which includes mostly New York business.
And I'm curious, can we compare your New York and your Vermont books of business? And are they moving with the same trajectory? Again, like I said, you're in this unique position where. So how are we doing compared to New York?
So I think I will state that the individual and small group markets are a challenge everywhere. I don't think those markets are very profitable in New York. They're still challenging markets, but we haven't sustained consistent losses in those markets. I think, like Sarah mentioned, there'll be a good year, a bad year, but a good year for, health insurance, frankly, is a 1% profit margin, right? You're not losing money. I would frame my answer in the context of the cost discussion, because I think that's a really important one, and definitely a relevant policy discussion right now about why the cost of care in Vermont is so much higher than it is in New York, than it is in New Hampshire for the same exact things. And, that's, I'm sure, due to a lot of complicated reasons. I would share that we are seeing pretty high cost trends in outpatient medical prescription drugs, like Sarah mentioned. I think lab services, MRIs, imaging, all dramatically higher in Vermont than just across the lake in New York. So, I'm sure there's underlying reasons for that. There's as I understand it, no real outpatient ambulatory specialty services in Vermont. So there's a bit of a, kind of a monopoly on these services and the price that you can charge. There's just not a lot of competition. I think that's, maybe one variable to look at, but I'm sure there's a whole range of complicated reasons. But the cost of care in Vermont is definitely trending higher in many respects than we see in other parts of our footprint.
And the rates, are you seeing the same trend with hospital charges that Blue Cross was seeing?
So I'm gonna plead not ignorance, but I don't fully understand. I've looked at the information Blue Cross has presented publicly, and I interpret that as a claim surge. Yes, we're seeing cost increase pretty dramatically year over year. That's definitely happening in Vermont. We are seeing that, but those are, we've had to make assumptions about what those increases would be, and we're not seeing anything as we sit here today that's dramatically out of line with our assumptions.
Okay. Thank you. Thanks for coming in. Any question? Oh, Daisy.
I have a question from a member that's not in the room. So what, in your opinion, is the solution to the crisis that we're seeing and experiencing here in Vermont?
That's a difficult one for me to answer because for two things. I'm not in Vermont, right? And so my work in Vermont is only dating back a couple of years. So I don't have a lot of the historical institutional knowledge about the evolution of the healthcare system. Just in internal conversations I have when we're looking at, the Vermont business and, policy environment in Vermont, what I would go back to is to really urge all policymakers to really think about a future state that can look dramatically different than it does today. I mean, just in terms of what's happening in, technological advancement and capabilities, I think there's a lot of opportunity to provide care in a more member-centric way. Just envision more services coming to you in the home, right? Meeting your needs. So, I think and I appreciate the difficult decision that policymakers find themselves in, right? You need to manage preserving access and, any deviation from that is very difficult in terms of any major disruption. But, I think the reality is the world is changing, and it behooves all of us to really think about, ways that we can move this forward in a reasonable and appropriate way.
Thanks, Jordan. And you are sort of a Vermonter, and you do have a responsibility because you represent so many Vermonters and you serve us. So thank you.
Appreciate that.
All right. Thank you. Thanks for joining us, Jordan.
Thank you.
Oh, was not for him. Okay. Thank you. Leslie?
So I'm curious to know if we're gonna have like DFR come and, talk about it from the regulatory, what legislation can we do, if any, maybe not, I don't know. Because it does sound like prices are driving the system, especially in the northern part of the state. And I don't know what our avenues are, if any, and there may not be any from this room. I don't know where the conversation is, and I'm curious about that.
I think we're having conversation.
So could you expand? I mean, people coming in here soon.
I think this conversation began because we were introduced to the two payers who offer qualified health plans, and they opened the conversation, but I have a feeling that this is a conversation that will be had throughout the session.
Is there legislation? I'm looking at what our, it's a very complicated space, clearly. I don't understand how to get our heads around it. Like, prices, we heard about prices. So can we deal with that? That's not our brief. I just want to understand what's our brief.
I don't know if we have a brief.
That's part of my question, right? If we don't, then we move on. If we do, then I think I want to understand it better.
I mean, Daisy, you're a legislator, you represent your district, you get to decide what you want to do about it, right?
No, I don't, because it's a very complex system, and I'm not interested in making any jerky, dumb work. I want to do work that makes sense. And I'm not understanding yet what that work looks like. So that's what I'm asking.
I don't think anyone understands I don't think anyone sitting around this table, I should say, understands what any of that work looks like. I know that we're being presented with information that frankly, I was not aware of, or I'm not sure who was aware of it. I'm not sure the public is aware of it. And frankly, I think we should be getting some information.
That's what I'm asking, exactly what I'm asking. Yeah. So are we expecting to have DFR come? I'm just asking so I can just say, okay, here's where we are today. It's not pretty and worrisome. And I think you said something like that. So what's our responsibility with this information?
Continue the conversation.
I think it's early.
And gather information.
So I'm curious to know from whom. Are we going to have DFR?
I am sure we will have DFR in here many times on many subjects. I am sure that we will have Green Mountain Care Board. I know we will be having Green Mountain Care Board in here, AHS. I know that we will be having the hospitals in here, University of Vermont Health Network. I know that we will be having all these people in here. And I think we're gathering information.
I totally get that. And I'm sorry if I'm being a pain, but I'm trying to understand. And, we have a deadline coming through for legislation. So do we just say, okay, first year the biennium is information gathering? Okay, I can get that. And then we think about it. And I'm trying to understand how we navigate.
I don't think we can decide that yet. I think
I'm not saying it's a decision.
all of the
I'm-
people that, all the groups that Melissa mentioned and more, we will be talking with them. I think it's too early to say what we will or won't be doing and when we will be doing it.
I'm not suggesting that, I'm suggesting about how's the conversation gonna happen, but I'm hearing it.
Oh, yeah.
Okay, I've been here 2 years. We made some great things happen in the state of Vermont. But we have to realize that we've got to realize in the future, for everything we do, that is a plus for our people in the state of Vermont, there's a cost. And I think we've forgotten that. And I think it's going to be some tough decisions and we've got to prioritize what is important and how we go about it. So it's not just healthcare. It's our whole system down here in the state. We think money is growing on trees and we've got to make some tough decisions and healthcare is top of the list.
Perhaps we'll hear more from Healthcare Reform Office. They may have some ideas in the future.
Another group we will have in through AHS. I think that's where they're housed now since they keep moving.
And I think
No, go ahead.
once we see the budget, I think it will be a huge part of the puzzle
Mhm.
because that's our major partner, right? Like, once we see what our options are, basically, like you said, everything has a cost, right? Like, once we see what our partners are willing to invest in, we kind of know what we're working with. And I think a lot of good ideas come out of there too. And once we see what those good ideas and plans are, then we have something to work with. And also, like, all the great ideas aren't necessarily sitting around the table, no offense, but they're sitting around the room. And that's why we have that chair right there. And I think just listening is, like Alyssa said, like gathering that information it's hard to be patient because we all know the urgency of the crisis, but it is so, so rich to sit here and listen and catch up with all of these partners that have been living it and trying to fix it since we left in May. When did we leave? Did we leave?
Although we've been back now for like
Yeah.
6 months, haven't we? It feels like it.
But we all recognize the urgency of that. It's good.
I think a lot of it's gonna matter. What goes up in that wall in the next couple of weeks? No, next 4 weeks.
Well, that's my concern, if I may, and.
And I will just, I'm going to interrupt you.
I'll shut up, but I
No,
don't know.
I'm going to interrupt you and I'm going to remind you that, we had legislative counsel in here who was telling us the various ways that bills are introduced and there is the committee bill process.
Well, I thank you, and I thank you, Topper, because that's my concern, but I just want to know, I just want to feel like a team. And that's what I'm asking for is, as our committee responsibilities. And I know we're all just starting and it's day, 2 minutes, but it's scary. And, the more you listen to, and my constituents are suffering, as is everybody's. And I have a responsibility to that.
I think we all know that. We're all worried.
That's just why I'm looking for an unfolding.
And I'm trusting in the process that we will get there. We need to have the conversations and I know they will happen.
And I will be honest, I will tell you my agenda. There are 11 people who sit around this table. And no offense to any of us, we are highly accomplished in many areas of our lives. But the 11 people that sit around this table are not going to solve this problem. There are some very smart people, some people who devote their lives to these issues. And my agenda is to ensure that the right voices and that we're listening to the right voices and that we're giving the tools to move us forward in a much more sustainable way. And that is what I feel as though the goals of this committee should be. It's not going to be us coming up with some grand idea that nobody's ever had before and fixing the whole healthcare system. But what we can do is we can ensure that we're listening to the right voices, and that we're providing the tools and the resources to the people who really actually can make a difference to help make a difference. Because I think as Blue Cross Blue Shield laid out to us today, I don't think we're in a very healthy spot. And our healthcare advocate sat in front of us yesterday and talked about we are on the precipice. So that's my agenda. Do you have a separate agenda, Topper? You're gonna fix it all? Sorry, I shouldn't be
No,
making jokes.
you shouldn't be making.
I shouldn't
like
be
that,
making
no.
jokes.
I will tell you this, there will be bills that will come into this room that we're not all gonna agree on, but they're gonna stimulate a conversation that will lead us in one direction or another. And like the chair said, we're not gonna solve it individually, but we're gonna make an attempt to do something positive. The whole gang of us. You'll see 3 bills that are gonna come in with my name on it. And one of them is gonna deal with hospital, the problems they have right now. I think there are a lot of people in this building that are very knowledgeable about one particular bill that I introduced 20 years ago. And now, just now, I hear hospitals, I talk to hospital administrators talking about, if we could have a global budget, we could do this. So there's gonna be a bill that's gonna do just that. Now, we may not pass that bill, but we'll come in here, we'll talk about it, we'll bring those people that are affected by it in here, and maybe we can work out something that will help that problem diminish some. Because if we lose our hospital healthcare system, we're in deep trouble. And we're on the verge of getting close to that. When I hear people talking about closing hospitals and so on, that scares the life out of me, especially in Vermont, because it's so rural. So we got to figure, we're going to have to look at these things. So I think it's safe to say is don't expect us to perform a miracle on that particular issue. I mean, you know, they talked about the Central Vermont Hospital, which I'm very familiar with, and the surplus, the reserves they had, and they talked about a mental health facility. That's gone.
Right.
They're not going to do it. So, and I know that, and the reason is they don't have the money. So we've got to figure out a way to take a look at part of this healthcare system, maybe the whole piece of it, and figure out ways that we can at least control the costs and then possibly keep the price for people around the same. I don't know if we can do that. I personally, my personal opinion is whatever we do is going to have some kind of a cost of living or some kind of rate setting thing so that each year in one of the bills, the hospitals, they're able to go up a little bit each year. And people are going to have to buy into it if they want to keep that system. If not, it's not going to happen, period. So let's not try to think that we're going to solve all of the problems. We're not. We know that. So let's just go at a pace. Let's get this part of the agenda over with, you know, the education piece, and then let's move into but
Yeah.
what is coming in from constituents, because that's what's coming in. And then we'll go from there. We pick what we want.
In that vein, you talk about the legislation you're introducing. I introduced H31. I introduced it because it was challenging for our payers with Act 111, and it was not an unreasonable request. And it wasn't unreasonable at all. And I remember I said in my report during the veto session when the other, I want to get that right and whatever it takes to get that right. So, I'd like to do something that helps our payers out because I think that they're incredibly stressed, actually. I'm going to give Wendy the last word and then we're going to.
I'll be really quick.
No,
I
you've
just
got
want to like play up.
17 minutes.
For those of us that are new here, like it just seems so big that it's hard to. I can't see a pathway anyone. Like, what is the worst case scenario? That it all collapses, that the insurances leave the state of Vermont, I just think if we had an idea of how big this, and you guys all know, I don't, but I don't have an idea, but it just seems to me that if we could like make it as big as possible, tell us what is the worst case scenario, and then we can kind of work from that point, I guess. I'm with you in that I don't know how to solve this. It just seems too, and I love that we're gonna have people come in and talk about it. I love that you're like looking out for providers too, because they absolutely just, we need them in this healthcare system, but it just feels like it's on the precipice that it's just gonna collapse. And I just would like to know what that would look like. If it collapsed.
You wouldn't have healthcare.
The what?
You would not be able to have people taking care of you.
Just for the people on watching, it's not gonna collapse, okay? We're not gonna lose everything. Okay, we are a vibrant state. We're gonna have healthcare. We've got our ups and downs. Right now, we're in a downslide. I don't want people to panic with people talking on, live here that are, we're down and out and, the world's coming to an end here. We, as a committee, will do our share. We will get the proper information from people. Like you say, we got some intelligent people that we got to utilize. And then it's not going to be just us. It's going to be the legislative body. But we can do this, and we will do it. So I don't want to talk doom and gloom, or else I might go home right now.
Okay, I'm gonna end this conversation regarding this. So, just to finish up, next week. Oh, I'm sorry.
Hi, are you still able to hear from Christine from Cigna? She's.
Oh my gosh, I am so sorry. My agenda got, Christine, I apologize. I apologize. I am so sorry.
I didn't want to interrupt.
No problem.
I threw something over my agenda here and.
I didn't keep you up to it.
Can you
this
hear
is
me? Do you still want to
Yes.
hear from me?
Yes, please, Christine, if you could introduce yourself, tell us your role in in Vermont's insurance market, and also if you could please comment on H31 as well.
Sure. And I just want to make sure you can hear me clearly.
Yeah.
Okay, great. So thank you for the opportunity to speak with you today. I'm Christine Cooney. I am Cigna State Government Affairs Manager for New England. I cover the 6 New England states, so Maine, New Hampshire, Vermont, Massachusetts, Connecticut, and Rhode Island, where I work with the legislatures, the insurance departments, and others across those states. I will just note that before coming to Cigna in 2018, my background is with the Connecticut legislature. I worked as a staffer there for several years before going to a state agency. So I have 23 years of state service, which just makes me appreciate all that you do, both you legislators and your staff, because I was there for a long time and saw it every day. So thank you for everything that you do. So I guess to start, I would have to note that Cigna works with a couple of great folks at Downs Racklin and Martin, who represent us in Vermont. So Becky Lewandowski, I know, is in the room, and also Patty Comline. So there are kind of on the ground counsel. There are day-to-day folks. As I mentioned, because I cover 6 states and I live in Connecticut, I'm not there every single day, but please know that you can always reach out to me. You can always reach out to Becky. And if I can get you information that's helpful, I would be happy to do that for you. So for just some real brief background, the Cigna Group is a global health company. We're focused on improving the health and vitality of those we serve through Cigna Healthcare, which is our health benefits provider, and Evernorth Health Services, which is our pharmacy care and benefits solutions provider. We're committed to enhancing the lives of our clients, customers, and patients. Our products and services include a number of health services such as medical, dental, behavioral health, pharmacy, vision, and others. We employ more than 70,000 people, again, nationally, globally, including some in Vermont, and we maintain sales capabilities in more than 30 countries and jurisdictions. We have more than 178 million customer relationships around the world. So obviously that's the very broad picture. But even though we are a national company, we are also local too. We have employees in Vermont. We have dedicated contracting staff and our market medical execs, so doctors who are licensed in the New England states and have a working knowledge of the intricacies of Vermont, who I work with on a regular basis when I'm looking for information on how to respond to legislators with questions about proposals that might be before you. We're very highly involved in, community engagement work in the local communities. And if you look hard enough, you will see, some of our staff out there in the communities providing, we're investing in community initiatives and volunteering and all of that. So I just wanted to kind of share that little bit of perspective. More specifically, and it sounds like you may have had a presentation earlier with specific data points, but our medical plan membership in Vermont is really primarily self-insured business. The majority of it is, which means it's governed by the federal ERISA, or the Federal Employee Retirement Income Security Act, but we do have some large group fully insured business in Vermont. So I just want to make that clear that we do have plans that are regulated by the legislature, by DFR. So that's why we are interested in the conversations that the legislature is having. And so I do appreciate that you have brought us into some of the conversations around the prior auth bill last session, the PBM bill last session, and as you've worked on some tweaks to the legislation, which I will address in just a moment, our thoughts on those. So I think the last reporting that we gave for one of the official reports was a little over 3,000 fully insured members, but our footprint is broader than that. One of the questions you were asking about kind of what are the tools and how do we solve some of these big questions that are out there around healthcare affordability made me think, one of the things I would recommend is just being aware that, especially in the self-insured market and the fully insured, I think employers, they know their employees and they're really looking to be able to craft health plans that meet the needs of the employees that are working for them. So as they're developing their health benefits, to have some flexibility and some choice in the tools that they can use or that we can use on their behalf, to help them drive better outcomes for patients, for their employees, for the members, however you want to describe them. I think, that's something that we're always working towards, and just being aware of any unintended consequences of proposals that could really be well-intended, but have a significant fiscal impact, for example, or actually have an impact on patient safety. So to the extent that I can bring examples from other states or maybe some best practices or things that have worked or things that haven't worked in other states, I'm happy to do that. directly or through Becky, if I could be helpful in any way there. So I can jump into the bill and my couple thoughts on that, unless you want me to pause and you have any specific questions for me, just in overview.
I just have a really quick question. You said you had 3,000, you covered 3,000 lives in Vermont, which is in the not self-funded,
Correct.
non-ERISA.
That was the last report, and it was actually 2023 data. We're
Okay.
just finalizing our 2024 data. So I'm sure the department or somebody has the official, updated numbers, but I can get you that as soon as we update our numbers.
Do you have any idea how many you have in the self-funded plans?
So it depends how you ask the question. And actually, I was talking with Becky about this last night. I can get you the numbers, but I asked the question and I got a few different answers based on how the data is pulled. So if you want to know, for example, how many Vermont residents versus how many employers based in Vermont have employees that live in Vermont, like there's a few different ways to slice it, but I would broadly say, and this is true of all New England, that around 85% of our book of business in any New England state is self-insured business. So it's really a smaller percent, maybe 15%. I don't want you to do the direct math and take 85% against the 3,000 because I'm not sure it's quite that simple. But if you give me the parameters of what would be most valuable to you in terms of data, I can certainly have that pulled. So we can follow up with you on that.
An estimate would be fine, but that's okay. Yeah, so if you wanted to comment on H31.
Sure. So on the claims edit section, this took me a little while to kind of unwind with my folks. Just it's a little bit complicated, but I think the punchline is that we'll comply with whatever the policy decision is here, and we can find a mechanism to do that. Right now, we are applying our claims edits to claims for members who are covered under an insured or an administrative services only non-ERISA plan that is cited in Vermont. So it's based on the member, not the provider or where the provider is. So we can certainly adjust depending on what the final decision is by the committee or the legislature. I think, we can be prepared to implement the bill as it was passed last session. But if there's a change, we can do that as well. So it's kind of going back to what someone said previously. I think it's, more of a policy decision, but we can likely adjust either way. So I hope that's helpful. And then on the prior auth definition, and again, I do thank you for kind of opening this back up and looking at it. I do think the proposed amendment seems to be more in line with what your legislative intent was. But again, for us, it's a little bit different because the Blueprint providers are all contracted with us, or all our contracted providers are part of the Blueprint. So I don't think that's as much of an issue for us. But again, I think we could kind of go either way and make it work.
But you do have contracted primary care providers that you have contracted specifically with Cigna, and they are credentialed or registered or indicated in your systems as a primary care. So you would be able to achieve that.
Yes, we have primary care. We have contracted primary care providers, if that's the question.
Great. Thank you. Any questions for Christine? Again, I apologize. Can I claim new chair mistake?
No problem. at all. And if I,
Rookie
again,
mistake. You're right. It'll probably happen even more when I'm in a wheelchair. Thanks so much, Christine. Thanks for joining
no
us today.
problem. If I can
Thank
be
you.
of any assistance, please do reach out. Thank you.
Okay.
Thank you.
All right, so we're done for the day. First of all, thank you for the week. I think we got a pretty good overview of a lot of the providers, challenges, advocacy. I think we got a lot of information about the system of healthcare in the state, where you'll be learning forever and ever. In our 101, I will say that I believe, Tuesday morning, are we having joint fiscal in?
Yes.
We're actually going to get a JFO 101 on budgets, which I don't think we've ever had before. So I'm actually really looking forward to it.
Tuesday, not Tuesday.
Tuesday morning.
What time?
After after caucuses and after.
In the afternoon.
I just want to be at the right place at the right time. That's all I'm asking.
It'll be on the agenda.
It'll be on the agenda.
What does the agenda typically come out, or what's your hope?
Friday afternoon.
Today?
Friday. There,
I mean, I can definitely look over the weekend.
it's very to be determined at this point. And the reason it's to be determined is, we need to, start with budget adjustment. And, so we need to speak to some of our, agencies and departments about the budget adjustment, because we have to have our recommendations on budget adjustment in by Thursday. So that only leaves us, essentially Tuesday and Wednesday. Marty?
I have a non-policy, couple things I need to bring up after, I just want,
Okay.
before everyone
Oh,
leaves,
sure.
after we end.
Anything else?
Hey, Kristen.
All right.